Assalamu alaikum and very good afternoon to all of you. 14th November, World Diabetes Day, provides an opportunity to raise awareness of diabetes as a global public health issue. As a result, we can better understand what needs to be done collectively and individually for better prevention, diagnosis, and treatment of the condition. I am Dr. Asya Nabi, Assistant Medical Director and General Practitioner at Prime Health, joined from our official social media channels. This year's theme, Access to Diabetes Education, underpins the larger multi-year theme of access to care. Today, we will highlight not only the challenges, but most importantly, the solutions to scalping up access to diabetes medicine and care. Thank you all for joining us today. If you have any questions related to diabetes, kindly mention in the comment box. For this webinar, I would like to first introduce my first speaker on this webinar today. Dr. M.S. Kumar. Dr. M.S. Kumar has joined us from our Prime Medical Center, Dera in Dubai. Dr. Kumar is a consultant endocrinologist and diabetologist with experience of more than 18 years or more than 2 decades in this field. He's an active member of the American Diabetes Association, American Association of Clinical Endocrinologists, European Society of Endocrinology, International Diabetes Federation, and other national and international organizations. But what you don't know about Dr. Kumar is for more than a decade or more, he has been contributing to diabetes health education to the society and make sure that his diabetes patients are aware of the next step in their diabetes journey. Welcome, Dr. Kumar. Dr. Kumar, you're on mute.
Thank you, Dr. Asya, for the introduction, and hello, everyone. And it's really a great pleasure for me to be here today. And I always make a point that we do something on 14th November. So now, after Corona, we have shifted to virtual mode, which is more easier and convenient for all of you. So I welcome you all for this webinar and the live webinar.
Thank you. I would like to now introduce my second speaker on this webinar today. Dr. Wissam Wahid has joined us from Prime Medical Center located in 06 Mall, Sharjah. Dr. Wissam is a board-certified cardiologist specialist with more than 9 years experience in this field. He has graduated from a medical school in Egypt. He completed his cardiology training at one of the largest tertiary hospitals in Egypt. Aside from his clinical outpatient department, he's also actively involved in corporate heart health programs, stressing preventive heart health for well-being. Welcome, Dr. Wissam.
Welcome, Dr. Asya. It's a pleasure to be with all of you.
Thank you, doctor. Now, I would like to introduce another speaker on this webinar. This is my also first time, we are doing a live session with him. Let me introduce directly Dr. Mandeep Lamba, who has joined us from Prime Hospital in Dubai, brings an outstanding experience of 2 decades of practicing ophthalmology and retina, being associated with organization with most modern and state-of-the-art ophthalmology setups. In his career, Dr. Lamba has performed over more than 7,000 retinal and 10,000 cataract procedures across the world. I'll say UAE, USA, Mauritius, Rwanda, Nepal, and many more. As an avid speaker, Dr. Mandeep Lamba has delivered close to 200 orations in various national and international ophthalmology forums. Dr. Lamba has performed live cataract and retina surgery several times at ophthalmology conference. Welcome, Dr. Lamba.
Thank you, Dr. Asya. Welcome to all my co-chairs and all the attendees. Looking forward to have a good, productive introductory session. And I hope we reach at some conclusion at the end of this session. So thanks for the
Thank you, doctor. Now, since this is World Diabetes Day, diabetes is really alarming now. And I'll just put it directly to Dr. Kumar that why diabetes has become a global issue and why this is really need to be considered as global epidemic as of now. Dr. Kumar, you're on mute. Please keep your mic on mute.
Yeah. So, Dr. Asya, diabetes has become a pandemic. And as you know that this is one of the very, very common lifestyle disease, which is increasing with time. So the main reason for increase in diabetes number is that the lifestyle of the people have deteriorated significantly over time. The type of food which we eat, the amount of exercise which we do has actually changed. The type of food which we are eating is not very healthy. The portions which we are eating, they are also not healthy. And most of people, they don't know what is their actual requirement. And most of people, they don't know how the requirement does get changed with the time and with the age. So if you see most of the time when we are seeing these patients, the middle-aged adults, males and females, they put on weight after they finish their graduation and they start working, and their focus on their health goes down, and they try to go for the quick fix food items, the fast food, and the easy availability of the food has also created a problem. Then the awareness about the food which is healthy and unhealthy is there, but the application is not there. Then the stress has increased over the time, and most of these patients, the young patients, they have family history, the genetic background. So with the genetic background, if the person is not careful, there is a risk of diabetes which increases proportionately with the age and with the time. So many times I have seen that people, they think that, okay, my parents have diabetes, I will not develop now, maybe in 40s and 50s. But I see patients as young as 15, 20, 25. So the reason for increase, these are the main reasons for increase. The wrong selection of food, a sedentary lifestyle, and the family background, the genetic susceptibility, and easy availability of food. And despite having awareness, now we are fortunate that we are living in an era where all the information is available very easily, but the application of knowledge is not there. So that is why we have started, and our digital team has started this awareness program, that when you get aware of at an early age, earlier the better, you can say that as soon as you get realization that you are at risk because of various reasons, you have to act on that. You cannot just sit on that and just think that, oh, I'm not going to have this. This is the biggest myth, that the person who knows everything, if he's not able to do that, we should tell them to use the health wisdom. We should tell them to apply health wisdom to take care of themselves and to prevent diabetes. If we can prevent, then only we will be able to tackle this increase. If you're not able to prevent, this will keep on increasing.
So, doctor, as you correctly said, a lot of information is there on social media. Now, world has become digital, but still we see a lot of rising cases, right? So instead, it should reduce, because a lot of nutritionists, a lot of doctors are also on the digital platform. Why do we still see the numbers are increasing? And where do you see actually numbers of UAE in next 5 years?
Okay, as I told you, the knowledge is there, but the mindset is not changing. The right application of knowledge is not there. Sometimes when the patient, they go to work, there's so much of information. If you discuss about the diet, everybody has a different opinion. Everybody has a different thought. So, sometimes patients, they get confused also what to do, what not to do. So application of the most important thing, that everyone should have a pledge to themselves that I have to take care of my health. My health is my responsibility. It's not my wife's responsibility, not my children, not my employer's responsibility. It's my responsibility. So that sense of responsibility should come. As we make the goal, our financial goal, our career goals, we have to make the goals about our health. That's what most of the people are not able to do that. I tell them that you have to have a goal setting. You have to start making small changes, because they are going to make a big change. You have to invest in your health from the beginning. You can't just wake up one fine day and you say, oh, my parameters are disturbed now, and suddenly you start doing everything. So it's a slow process. The prevention and the behavioral change is a slow process. We have to educate our next generation that this disease can come because our fathers or forefathers or most of the people have family members with the diabetes. So we have to tell them that you are at risk. That communication regarding health is very important in the family. and at the group level also. Then only the mindset will change. Once the mindset start changing, everything will start changing.
Absolutely, Doctor. At Prime, we definitely believe in empowering education to our employees so that they can actually decide what is right for them. And I'm sure they will be here. I would like to share that today we have a very lovely audience who are engaging from different parts of the world. This message is for the audience. Keep engaging, keep asking questions, and let us know from which part of the world you have joined us. If you're from UAE, you can also let us know which part in the UAE you have joined us. And we have also a surprise that we'll be asking a question in the end of the webinar, and you will get a completely new concepted AI-driven health package to let you know your risk of diabetes, your risk score for diabetes or heart disease in the future. So I'll proceed further. Doctor, since we are here, so what is who is at risk for diabetes? If you can quickly let our audience know what should we look for. Okay. Like you said, youngsters, we have designated this disease kind of like, people after 40 or 50. But what others should know who never have been to doctors, or even if they go for upper respiratory or just basic things, back pain or shoulder pain or neck pain, but they actually never drive their attention towards at least screening of diabetes. What do you have to say for them? Who are the people who should actually come forward to check if they are under risk factors?
Okay, so first and foremost is the family history. If anybody is having any family member, whether immediate, first degree, second degree, they should be cautious. They should think that the diabetes can come to them. So this is the first and foremost. If there's a very strong family history, these people should be screened at much younger age. Even I will tell you that from the age of 15 or 20 or 25, you can say, because we see a lot of patients of age nowadays 25 to 30. Then the first warning should come from the family members or the parents that, look, we have diabetes, or your grandparents have diabetes, mind what you're eating, and stay active and maintain your optimal body weight, because those are the things which are going to prevent. So mindful eating should be practiced in the family. We have to prevent. There, the first education starts from the family itself, if somebody is having family history. Then the second is that people who are obese are overweight, of certain ethnic origin, like South Asian, Middle Eastern, they have more risk of development of diabetes. So any person who is obese with the family history and of South Asian or the Middle Eastern origin, and then if they have sedentary lifestyle, then if somebody is a smoker, and if somebody is having family history, a female, if she comes that if she has a history of gestational diabetes in the past. So these are, and then ladies who have polycystic syndrome or polycystic disease, they are also at risk. So these are some common risk factors which can tell the person, which can actually tell the physician to screen that person at much younger age, because the guidelines which have been set in the US and Europe, where the diabetes comes 1 or 2 decades later, are not applicable to our population. For us, we can start screening as early as 25, or if the obese are overweight person, if the family history is strong, even the age of 20 or 15 itself also, if the obesity is there.
Thank you, Doctor. Thank you very much. I'll move on to Dr. Mandeep Lamar now. As a general practitioner, doctor, I have a concern that when a person is diagnosed with diabetes, they're really not bothered, even if the physicians tell them that the first thing after diagnosis with diabetes, that diabetes is a multidisciplinary approach, and they should also visit the ophthalmologist. First of all, is this treatment correct? And if this is correct, then what is the recommendation for anyone with diabetes?
That's absolutely correct, Dr. Asiya. First thing we need to remember is when you are diagnosed with diabetes, I mean, Dr. Satyendra has very well summarized what should be your first game plan. I always tell my patients, don't panic, relax. What you need to do is figure out who is going to help you to see through this diabetes, the face of diabetes, because it's going to persist for life for most of the patients. So figure out your endocrinologist who's going to treat you throughout, probably for your life. And also get other systems evaluated like cardiology, nephrology, ophthalmology. So that's important. And obviously, the most important point here is make sure that your doctors are fixed. You don't change doctors, don't jump hospitals. Preferably, if you can, have all your specialists under one roof. That makes a hell of a difference, because all your medical records are maintained. These days, everything is linked. So if I have a patient from Dr. Satyendra, I can actually go in and see what his recommendations are, how his controls are, and vice versa. So it's not always that diabetes is detected and the ophthalmologist is required. Contrary is also true. I have got many patients who come to me for some kind of vague symptoms or vision loss, and I diagnose them as having diabetic retinopathy. But when I tell them that, listen, do you have diabetes? They said, no. I mean, there's no
Doctor, I'll just ask you to explain what is diabetic retinopathy, because this is our audience probably will not understand what is diabetic retinopathy.
Right. So diabetes affects different systems in the eye. Body has different systems. Similarly, eye also have different systems. All right. So if I can explain it to you in a better manner. This is a model of the eye. You see that?
Yeah, I can see that. Little above, doctor.
When you open this cross section, all right,
Yeah.
front of the eye, when you look inside, you can see the blood vessels there.
Yeah, we can see the arteries and veins.
Are basically retina. So eye has got front segment, it has got back segment. What you see outside is just 1/6 of the eye. What you don't see behind is the 5/6 of the eye, which is richly supplied by blood. So when you have blood disorders, which diabetes affect it, blood disorders, it's kind of metabolic and blood disorder, right? Or hypertension, it starts affecting all the blood vessels. And actually, most of the blood vessels in body are not seen. It's only in the retina, inside the eye, that you can see what are the changes happening in the blood vessels. And that is the reason endocrinologists or general physicians refer their patients to us to actually screen and see what is the condition of the blood vessels inside the eye. Now, when you talk of the front of the eye, diabetic patients can experience, or most commonly they experience, something called as dry eye. It is very common, and it simply means that your tear formation becomes defective. The components of tear formation becomes defective, and this is the most common complaint with a diabetic patient comes to us with. Staying with the front of the eye, diabetes can affect you in terms of having glaucoma. Glaucoma simply means high pressure in the eye, which can affect the optic nerve, or the nerve which carries the signal from eye to the brain. The damage is irreversible, and hence, whenever a patient comes to us, we make sure that we rule out glaucoma in these patients. Third thing it can affect is having a cataract. Cataract is reversible, what we call in Arabic as a Maya Veda or white water. Again, diabetic patients of post the age of 55, 60, almost everyone has certain grade of it. So that's in front of the eye. The back of the eye, whenever diabetes affects back of the eye, it's called diabetic retinopathy. So these blood vessels, they start leaking blood, they start leaking fluid. There is a pattern. We can recognize this pattern, and we can actually tell the patient that, listen, you are diabetic for at least 5 years, or at least 5 to 10 years. And often, this patient, I've never been diagnosed as diabetes. I said, fine, go to an endocrinologist, get your workup done, and they actually realize that, yeah, they have been having diabetes, they just didn't know about it. So it's pretty common these days, because as Dr. Satyendra mentioned, previously we used to think that diabetes is an age of old age. Now, it's not the case. All right, so we often see young patients coming to us with diabetes and being diagnosed as diabetic retinopathy. Now, as physicians, our responsibility basically is not to guide them throughout the journey. My job is not actually to treat the diabetic retinopathy, but to make sure that this patient has productive vision till the end of his life. So, for example, a patient comes to me with early diabetic retinopathy at the age of 35. And let's say that he's going to be alive till 70. If this diabetic retinopathy is going to kill his vision by 40, 45, my job is to make sure that this person from 35 till 70, at the age of 70, you should have good persistent vision, if not normal. That's and again, all these factors like control, compliance, good compliance is required. Frequent change of doctors is a horrible habit, especially in this part of the world. So if you don't like a doctor, fine, change it once, twice. Don't keep jumping doctors because the treatment protocols are very, very rigid these days. They're very strict and they have to be followed in that particular manner. So we are all here to help you. I'm pretty sure about it. And um, yeah, it can be frustrating because the treatment is going to take time consuming. It goes in years, sometimes not only months and days. So that is probably one of the main reasons why patients tend to drop out from the treatment regimes.
Absolutely, Doctor. Thank you so much for that elaborative knowledge. I'm sure it's going to help everyone. Just out of curiosity, that okay, a patient is coming to you after 4 or 5 years. Since you're a retina specialist, do we have any advanced kind of technology which can see all this eye front and back and can still, even if it is 5 years or 10 years of diabetes, is there any kind of technology which can still help prevent the vision loss in another 10 years?
See, when it comes to diagnostics, we are equipped with something called as multimodal imaging. So whenever a patient comes to us, first thing we do is we dilate this patient, we look into the back of the eye, we see if there are any signs of diabetes, hypertension, or diabetic retinopathy, and even let's say if he has lipid profile disturb, we can find it out because the cholesterol pigments actually gets deposited into the retina. Now, once we have done a basic clinical assessment, we do certain advanced assessment for these patients. We have got equipment like OCT, called as optical coherence tomography, which can actually take the cross section of each and every layer of the retina. There are 10 layers of the retina or Shabakia, and we can find out the health of all these 10 layers one by one. Then we have something called as OCT angiography. Angiography actually looks beyond the retina into the next layer of the eye, which is called as choroid, and we also try to make sure that there is no disease process happening from underneath the retina. Then we have fluorescein angiographies and ICG angiographies, where we inject a dye, take photographs with the help of a filter, and we can actually, all these points of leakages and the blood vessels actually glow up. So when they glow up, all the defects also glow up. And when they do, we are actually able to stage this particular patient or our patients, and making sure that we tell them that, listen, you have got this stage of disease, and this is going to be the way you will have to follow us up, or you would require treatment or not require treatment. Everything depends on staging of the diabetic retinopathy. It also gets a little complicated in terms of what areas, whether there are involvement of critical areas in the retina, or there is not an involvement of critical areas of the retina. I mean, we can just go on, and treatments actually depend on that. For glaucoma, yes, we have visual fields. Again, OCT helps us to track the optic nerve. We have got anterior segment OCTs, which tell us whether there is any defect in the front part of the eye, or do we have any defect in the lens, which can actually be diagnosed well, and finally a verdict can be given to the patient as what we want to do as a next step.
Thank you, Doctor. It really, truly is informative, and I believe this needs a whole, complete, separate webinar so that our people and patients can get more benefited out of it. Quickly, Doctor, what is the recommendation anyone with diabetes? How frequently they should come to see the ophthalmologist?
Initially, if you are just being diagnosed as having diabetic and no diabetic retinopathy, we see these patients once in a year. If you have any stage of diabetic retinopathy, then we follow the American Academy of Ophthalmology recommendations, which are very crisp, as in X stage will be followed in 6 months, Y stage should be followed every 3 months. And yeah, there are certain patients who are actually bleeding inside the eye, which is extremely advanced stage. We call it as proliferative diabetic retinopathy, where actually the bleeding happens inside the eye, and these patients are at risk of developing retinal detachments. That's sight threatening. So we even see them on a monthly basis. So it's not one fit for all. Actually, it's a retinal surgeon who decides how patients should be seen, and it's all very well guidelines, very well dictated.
Thank you, Doctor. Now I'll move to the Dr. Wissam. Dr. Wissam, how does type 2 diabetes changes the risk for heart disease? Doctor, you're on mute. Please unmute yourself.
I'm sorry. Dr. Asia, when we talk about diabetes and cardiovascular disease or heart disease, we always put diabetes in a separate position, like it's an independent risk factor for heart disease. What do you mean by independent? Heart disease has so many risk factors, and by risk factors, we can say like causes for heart disease. Diabetes can be treated like a separate factor because it's one of the most important causes and risk factors for heart disease. And they even estimate that the risk factor, the impact of diabetes on heart disease is equal to double or twofold. Like if you have diabetes and if you don't, if you have diabetes, you are at two times more at risk of having heart disease if you don't have diabetes. So diabetes is one of the most serious and crucial risk factors for heart disease, and we even treat it as an independent factor, regardless of other causes of heart disease.
Is weight a really concern for people with diabetes or without diabetes and having heart disease?
Yeah, definitely, Dr. Asia, weight is a major concern. As I said earlier, heart disease has many, many causes, not just one cause. Diabetes is one of the most important causes, but we have other causes of heart disease, including high blood pressure, including high cholesterol, smoking, alcohol consumption. Weight is one of the major risk factors. And when we talk about weight, we don't just talk about how many kilograms or pounds you weigh. No, we depend or we rely on two things. First, we rely on something called the body mass index, which is the relationship between your weight and your height. Because if you are a short person, then it's acceptable. Your weight should match your height. Or in opposite, if you are a taller person, then your weight should match your height. So we rely on an equation called body mass index, which will determine if you are in a good weight or you are underweight or you are overweight or you are even obese. The second point we focus on is not just the body mass index, but also the distribution of the overweight. Where is the extra fat located in? Is it mainly in the waist area? Because this is the most important or the most serious location of fat. When we see that the patient has a big waist circumference, which is higher than 94 centimeters in male and 88 centimeters in female, then yes, you are at high risk of having heart disease. So it's not just the weight, it's a relationship between your weight and your height, and where is that extra weight located in your body.
Thank you, doctor. So if a person is diagnosed with diabetes, a young person diagnosed with diabetes, and he would like to seek your opinion to prevent heart disease in the future, probably 5 years, 10 years, or 20 years, how we will proceed? What should be the advice for everyone to know?
Excellent question. As I said, diabetes is a major risk factor and it's an independent risk factor. And every time I approach a patient with diabetes, I ask myself 3 questions. First, I have to focus on 3 points. First of all, diabetes is a systemic disease. As Dr. Kumar said, it affects all body organs, starting from the brains, the eyes, the heart, the kidneys, the blood vessels of all the body. So I have to first check if there is any affection of this diabetes affect any of these organs or blood vessels or not. Second, diabetes is a disease of duration, means that the longer you have diabetes, the higher risk you have. So I have to ask the patient, for how long you have diabetes? Is it just recently diagnosed, or you have it since 5 years, you have it since 10 years? Because duration is of a crucial matter. Third point I have to focus on is the control. Is your diabetes or your blood sugar controlled? Are you taking medications? And are you following up regularly with the sugar doctor? And it's your blood test controlled, including the glycosylated hemoglobin, which I'm sure most of the diabetic patients are aware of, because they should follow up that at least every 3 months. So I ask the patient several questions, including the symptoms. Do you have any symptoms to indicate that you have any organ affection? Do you have blurry vision? Do you have chest pain? Does the color of the urine changed? Is it bloody? Is it frothy? Does it show any abnormalities? I ask him so many questions, including the duration of his diabetes and the control. Is he taking his medications or not? And according to the suspicion, if I have high suspicion, means that this patient has diabetes for more than 10 years, and he's not controlling the blood sugar, he's not compliant on his medications, and he has chest pain. Definitely, this is something I have to put into consideration. And based on that, I will do further investigation for the heart. And as I said, diabetes, when we learn that the patient has diabetes, this is something that has to be taken seriously, and we can do even up to visualization of the blood vessels. If the patient has chest pain, we can do coronary angiography even if needed, just because the patient is diabetic for a long time.
Thank you, doctor. Now I'll go on to some question answers which we already some people have asked. So, Dr. Kumar, this question I would like to bring to you. I believe he's trying to ask about immune compromise when diabetes is there. So, would you like to put some highlights on this? So, Mr.
Yes.
Atikur Rahman, yeah.
Yeah, it's a very good question actually, Mr. Atik, and your point is very valid. Yeah, when the diabetes is not controlled, this hyperglycemia, actually it can compromise the immune system and the defense mechanism. The neutrophil response gets affected. And that is why whenever the diabetes is out of control, we see that these patients, they get predisposed to different infection and they develop infection. Even if you recall that during the pandemic, COVID-19, the worst mortality and morbidity was with the diabetic patients because of and particularly who had uncontrolled hyperglycemia. So there's no doubt that yes, like 3 days back, I had one patient, sugar was very high. He was not taking the medications and he developed the cellulitis, or the infection in the abdominal wall. Yes, uncontrolled diabetes can compromise immune response, and these patients may develop more infections, whether it's a skin infection, a urinary tract infection, or genital infection. Any kind of infection can be increased.
Thank you, doctor. I have a question for Dr. Lamba. Ms. Sunita is asking, husband underwent phacoemulsification cataract surgery in both eyes a couple of months ago. HbA1c was 11 before surgery, and with strict diet in 3 months, it was brought to 6.8. Congratulations, Ms. Sunita. Will he still suffer from diabetic retinopathy?
See, diabetic retinopathy, whether he will suffer or he will not depends on different factors. HbA1c is just one ingredient in it. Duration, other comorbidities, what is the control, what is the fluctuation in the diabetes. We always tell our patients, it's fine if your sugars are like 180. It's okay. It should not be like 250 one day and 80 the other day. So those wide fluctuations causes more harm than actually having mild high sugar levels rather. And going to what Ms. Sunita is asking, it's very difficult for me to comment about what if his HbA1c has been brought down to 600, he will still develop diabetic retinopathy. First thing I need to know is, does he have diabetic retinopathy at that point, at this point or not, right? Because if his HbA1c was 11, how many years it has been 11? So, I mean, it's difficult to actually comment right now. But I have a very interesting thing. There are beautiful apps available right now. You can download it from app stores. And one such app was shown to me by one of my patients. It's called Retina Risk. All right. You put these data. You put HbA1c, your average blood pressure levels, how long you have been diabetic, what kind of control you have, and it's a meter, which gives you a very rough kind of estimate that what are the chances you have that you will actually develop diabetic retinopathy. So it looks something like this. It asks for 3-4 parameters, which these are hypothetical parameters. So HbA1c is 10.7 here, right? So it shows that there is 30% chance that in next 1 year you will develop some kind of diabetic retinopathy. But these are crude methods. We need to see you first of all. Again, having cataract surgery done or not done has got no correlation with diabetic retinopathy. All right. So if you're maintaining 6.8 or what you said, perfectly good. If you can just keep on doing it, well and good. Just see one of the retina specialists. That's extremely important to know whether he should not have diabetes already. If he's not having it, he's having good control. Good, go ahead. No problems.
Dr. Asia,
Thank
I
you.
would like to add.
Yeah, please go ahead, doctor.
You tackled very well. Actually, what is important thing to remember for the patients and the physicians, the good and bad glycemic memory, our legacy, what we call. Now, this at one point of time when you're asking A1C is 11 and it came to 6.8, if suppose it remains 11 for many, many years, it has already set a bad glycemic memory or legacy, which is going to be harmful for some more years unless you replace it with the good glycemic memory. And that will be built only when this HbA1c of less than 7 or 6.5 to 7 is maintained for many years. So that is very, very important to remember. If for the first 10 years your sugar was uncontrolled and it remained high, you already set a bad glycemic legacy of memory, and the harmful effects are going to be visible soon. And it is not going to be replaced very fast with a short-term good glycemic control. And that is why we emphasize on early optimal glycemic control, because we want to prevent all the complications, and which is doable and possible. Once the complications they stop in, many years of uncontrolled diabetes, even these are complications they happen, most of them are irreversible. So we have to empower our patients with this thought, with this information, that try to build a good glycemic memory and have a comprehensive control of lipids, nutrition, and sugar all together.
Absolutely. I remember Dr. Kumar when I visit initial days around 7-8 years back. He always used to say diabetes make us disciplined. So I believe diabetes, other way around, is a journey which has to be lived in a proper disciplined way. So that should be the message for all. And control is the only thing. When your blood sugar controls are optimal, this can give you a chance of living a proper health and well-being. Dr. Wissam, I just have one question. During whenever we do any kind of webinar, we have some questions from the staff or people who don't want to come online. One important question: if a person is diabetic and wants to prevent himself completely from heart diseases because of the complication of diabetes, he has no other cholesterol, nothing else, only diabetes in life. His weight is normal, his lifestyle is fine, but because of probably the family history, he's already a young diabetic, and he would like to prevent himself from getting into heart disease because of diabetes. So what is the recommendation for such people?
Excellent question, Dr. Asia. First of all, I have to know where he stands. We have to know where the patient stands. Is he already affected by diabetes or not? And not just the heart, including the eye, the kidneys, the blood vessels of the hand. Is he already affected or not? If the patient is completely healthy and he's not yet affected by diabetes, this is what we call primary prevention. Means that we are trying to prevent something before it happens. And the main tool to do this, or the main management, is, as you said, discipline. The patient has to keep his blood sugar controlled. Blood diabetes, as I said, is a disease of duration. Means that if you don't have any other risk factors, just diabetes, you don't have high blood pressure, you don't have high cholesterol, you don't smoke, you are not overweight, you are exercising properly, and you are eating healthy, then this is excellent. Your risk is is much less, but still diabetes is, as we said, is an independent risk factor. So we have to keep your blood sugar controlled as much as possible. And what does it mean, controlled? Controlled means that your HB1C is at least less than 7%, or even if you want to go for tighter control, less than 6.5%. And I have to know where he stands from the heart. I have to do ECG, I have to do echo to make sure that everything is normal. If the patient has all normal investigations, then as I said, you have to keep following the same regimen, take the blood sugar medications, control your diet, follow up regularly with the eye doctor, with the blood sugar doctor. And this is the only way to stop or prevent heart problems from happening. Still, is there a risk of having heart problems even if it's controlled? Unfortunately, yes. There is still risk. We are trying to lower the risk, but still there is some risk. And as we age and as we grow older, the risk increases. But what we can do at the time being is just try to lower the risk as much as possible.
So, doctor, recommendation is after obviously the endocrinologist or internal medicine specialist or general practitioners, once they diagnose the diabetes, as we say that it's a multidisciplinary approach, at least once in a year, super specialty visit also recommended. So, if a person is without complication, he has to see a cardiologist as well, right?
Yes, definitely. One of the main reasons even the patient appears healthy, does not have any symptoms, because heart problems in diabetic patients are very atypical. They don't present in the classic way like patients without diabetes. For example, a patient who is not diabetic, if he has blockage in the blood vessels of the heart, he will present classically with chest pain, heaviness when he's doing any effort, when he's stressed. In diabetic patients, especially with long-standing diabetes, sometimes there is no pain. There is just shortness of breath or difficulty breathing. He feels that I cannot breathe normal. My breathing is high when I do mild exercise. So yes, even if the patient appears to be healthy and he's diabetic, he has to visit the cardiologist even once and to do the investigations. And based on what we found in investigations, we will decide the further management plan and the follow-up appointments.
Thank you, Doctor. Dr. Lamba, thank you, Ms. Prachi, for asking this question. I think we have already cleared a little bit of it, but I believe we can just recap again. Do we have any advanced retina screening available to prevent diabetic retinopathy?
Yeah, Dr. Asya, as I already mentioned, that multimodal imaging is the mainstay. Okay, there is no one-stop-all solution for, we have to these patients undergo, patients who are sent to us for diabetic screening or who already have diabetic retinopathy. They are periodically screened with OCT angio. Sometimes we require to do a full-blown angiography with the dye, which is called ICG or fluorescein angiography. So these things actually are required, and that's the mainstay of staging diabetic retinopathy. When we do,
so doctor, sorry, doctor. When you say angiography, is it something similar to heart angiography, or it is a simpler form? Like, do we need to get admitted, or how does this help?
Thanks for asking that question, Dr. Asya. It is nothing to do with the cardiac angiography. It is nothing like cardiac angiography. It is an OPD procedure. Patients don't have to get admitted. Patients you routinely book a OPD appointment. Come here. The dye is actually injected through the vein, just like an IV injection, and the whole procedure takes not more than 6 minutes. So there are different stages when the dye passes through the blood in the eye, blood vessels in the eye, and they're photographed in early, mid, and late phases. And readings are taken, and interpretation is made on the basis of that. So, total duration a patient has to stay with us is 1 hour, no admission required. It's a very safe procedure. It is contraindicated, or it should not be done in patients who are suffering from kidney failures, or who have acute ischemic heart disease, or who recently had any kind of MIs or heart attacks. The only drawback is certain patients have certain kind of allergic reactions. They develop some kind of small blisters on the face. That's 1 in 100 patients. All right, and we have backup. We do give antihistaminics to these patients to make sure that they are cured in the hospital and then they are discharged. Just one important thing, these patients, this dye gets excreted through the kidney, and you will have yellowish color or greenish color urine for next 2 days, which scares some of the patients. This is normal. It's just like any other medicine which goes through either liver or kidney, and these dyes are excreted through the kidney. I mean, that's about it. We compare this along with the other imaging techniques, and then finally we are able to decide. There are certain aspects of diabetic retinopathy which we cannot decide without fluorescein angiography. For example, certain class of patients start developing closure of the blood supply in the eye. It's pretty advanced, quite hidden. Even doctors, when they examine in routine method, they will not be able to make this thing up. So angiography actually tells us on what areas, what corners of the eye, the blood supply is actually stopped or stopping. So we go ahead and laser photocoagulate those areas or do laser on those areas so that dying retina does not create problem for well-functioning retina. So that's the use of multimodal imaging.
Thank you, Doctor. Thank you for that elaborative things. I'll take now questions because a lot of questions have to be answered. So, Dr. Kumar, a lot of questions are waiting in queue for you. So, one question is from Mr. Wasim. So, questions: why diabetes start? Which of the wrong things Doctor do it? Can explain? I don't know. Maybe he's trying to say that where we are wrong and why diabetes develop. So, we just simplify it for people, Doctor.
Yeah. Just to simplify it, that when we consume more than our requirement and we don't do the physical activity as required for our body, and when we overindulge in caloric dense foods like soft drinks and juices and things which are made of refined carbs, and then we have some kind of stress with the genetic susceptibility. All these factors can trigger the development of diabetes. Sometimes we have seen that patients who are at risk, there's a bereavement stress. Suppose somebody died in the family suddenly. That can also precipitate sudden job loss, sudden change in the job. So these are some precipitating factor in predisposed individuals on the top of their suboptimal lifestyle in terms of. So these are the main reasons. And overweight and obesity.
The other question is by Mr. Sabri. He's a diabetic B, probably type 2 diabetes, grade 1. His question is, should he take the medicine even if his sugar is low? He's usually taking 2 tablets a day before food. So probably he mean to say that his blood sugar is controlled and he's on 2 medications. Should he continue taking it?
Well, this decision is taken together by him as well as his treating physician, because without seeing him, without checking his medications and without knowing the reason for low sugar, I will refrain from advising him. So suppose, because nowadays we have so many medications which do not cause low sugar. So if he is taking some medication for low sugar, he should immediately contact his treating physician so he can adjust the dose, or he can shift him on the medications which are safer and which do not cause low sugar. And we have to make sure also sometimes what happens when the patients see the doctor, some of the patients, they change their lifestyle drastically and doctor doesn't come to know about it unless they see again. That drastic change in the reduction in the calories and exercise can also bring down the sugar. So the patient should inform the doctor that I started this, probably my dose are to be adjusted. So the best thing is to see the treating physician and discuss with him, and most probably they will either change or reduce the dose.
The other question is asked by Ms. Luba, and I believe it's a very good question for all the doctors. Probably we all can relate to it from our specialties. So she's asking question: has the normal glucose level range has changed with time in years? And my opinion question is, does food adulteration plays an important role in being susceptible to diabetes in spite of buying fresh fruit and vegetables? And my final question, so probably first is the adulteration of food and the safety of the nutrition. And her second question is, if a diabetic person has been maintaining glucose level with any normal range or borderline, should they continue to take medication or they can maintain by diet? So probably I would like to simplify it for the audience to know. So for example, a person is completely controlled, she or he is in a reversal state. Should does that mean that the person has to stop the medicine and can continue on diet? So all the doctors, from your perspective, Dr. Kumar, please go ahead first.
It's an extensive question, so we'll take it. So first is that the normal glucose level range has changed with time. It has changed, but for the last 10 years, more than 10 years, it is nearly constant. Now, so what is the reason behind that? The reason behind that is that what they found in the retinopathy was the first actually microvascular complication on the basis of which the HbA1c target was decided. Because what they found with the HbA1c of 6.5 plus, the risk of retinopathy start increasing. From 6.5 start, and from 7 it starts increasing significantly. Other complications like nephropathy, they start to increase after HbA1c of 7. So retinopathy is the first microvascular complication which can develop in patients who are even not having very high sugar, from 6.5% plus or 7 plus. So yes, the level range has been changed to benefit the patients, because even if we are trying to bring down the target to less than 7%, it's still 40 to 50% patients are not reaching to that target. And think that if the target is 8%, I think 90% will not be able to reach, and we won't be able to prevent majority of the complications. So the range has been changed to prevent the complication and to prevent the disastrous consequences of uncontrolled diabetes. The second question, food adulteration. Yes, it plays an important role. These are known as endocrine disruptors. Whatever we eat, how much pure it is, nobody knows. And the pesticides or whatever chemicals are being used, even in all the fruits and vegetables, we really don't know, but they are disrupting the endocrine system. And that is why diabetes and thyroid problems are increasing. There's no doubt. But at least if you buy the items which are fresh and which have, like your food is having more fresh fruits and vegetables and all, at least they have some antioxidants also, they will counteract. But if your diet is faulty, and if you don't have sufficient vegetables, fruits and the healthy items, then the impact will be more harmful. The third one, that if the patient is maintaining, a person is maintaining the sugar level in the normal range. Now it depends at what situation patient has presented to the doctor, and in how much time the patient has improved, and whether the patient developed any complications or not during this time. So patients who are diagnosed and they immediately start changing their lifestyle, they lose weight, they take medication initially, and then medications can be reduced and stopped in some of the patients, not in everyone. Now, one important thing to remember here, that even if you or your doctor has stopped the medication, don't be under the impression that the diabetes is gone completely. You are in remission. You are not cured. There's a difference between the cure and remission. Remission means you are in a state of HbA1c of less than 6.5, and you're trying to maintain your levels within the normal range, in a certain normal range, and without any medication. But any time there is a slip, you lose the track on the track of discipline of lifestyle. If you start eating the wrong stuff, if you are stressed, or maybe if you have stopped doing exercise, then it is going to come back. And when it comes back in a bad way. Because during this time, and what I have observed, that patients think that I'm in remission, patient perceives as secure, they stop checking, slowly their wrong habits, they come back and they go back to the original. So if you are stopping medication, you have to commit with yourself that you are going to stay optimal discipline. You will keep on maintaining your sugar levels to the normal range, and you will keep on seeing the doctor once in 3 to 6 months so that you don't be stressed.
And also self-monitoring every day, almost, or weekly, is a very important part of it.
Weekly or 10 days, whatever it is, but don't lose the track. If you lose, if it comes back, it will be in a much worse situation, and you will need more the medication. In some patients, are not sure about their discipline, and if they think that the discipline may go here and there. We keep them on a minimum medication because life is not same in 365 days a year. Most of the time, people, nearly 3 to 4 months, people don't do exercise. There are so many festivals, traveling, and that time discipline goes for toss. And that is the time when the sugar increases. So it all
Thank
depends.
you, Doctor. As we are proceeding towards the end of session, I will just
We can't hear you clearly. No, we can't.
I cannot hear.
Dr. Asi, are you with us?
I think she's going to rejoin.
Yeah, probably some disruption.
Doctor, can you hear me?
Yes, we can.
Yes, Dr.
Yeah, okay. So please proceed, Dr. Wissam. If you want to add to this question, because it's a very important question from cardiology or even ophthalmology point of view, when food adulteration is there. So does it really increases the heart risk as well?
Food adulteration is very important. Yes, definitely it will decrease the risk of heart disease, definitely. Because anything that will improve the blood sugar control will definitely decrease the risk of heart disease still. And also regular exercise, not just dieting is definitely very important. Also regular exercise is very important, especially when you keep your heart rate in the target heart rate zone, which is calculated by a simple equation. And I think everyone already now has a smartwatch where you can calculate your heart rate. So I always advise my patients to calculate their target heart rate and use the smartwatch while exercising to maintain the heart rate in the target heart rate zone. With food control, with the diet alteration, definitely together they will have the best result.
Thank you, Doctor. Dr. Mandeep.
Regarding adulteration?
Yeah, so anything like important to heart health, eye health and food, because food is a very big concern in anyone's life. Or probably we can put it a little simpler for our all patients to know, is there anything, any kind of food they should eat to improve the eye health?
See, there is no direct correlation between the food we eat and the eye health. It's only the green leafy vegetables which have carotenoids, which are required for the good functioning of photoreceptors, and that there is only correlation shown. But yeah, as my other colleagues have pinpointed, okay, if you have good cardiac health, if you have good diabetic controls, whether be it because of adulteration or because of any other reason, that definitely affects the health of the eye and health of the retina.
So, doctor, if anyone is affected with diagnosed with diabetic retinopathy, do we also suggest multivitamins? Because multivitamins is like an additional topic to be discussed, where everyone wants to take a multivitamin, whether actual medicine is taken or not. So, what is your thought process and actual recommendation for all of us to know?
See, for diabetic retinopathy, there is no recommendation of taking multivitamins at all. Multivitamins in earlier part of this decade was recommended for something else. It was called as age-related macular degeneration, where there was a formula given by AREDS study, and we used to prescribe it to every old person any issues with the retina. But even the latest studies have shown that the absorption through these tablets or medicines is not that effective. Effective it is from the normal dietary sources. So I don't recommend multivitamin for any of my patients, even for age-related macular degeneration. Definitely not for diabetic retinopathy at all. It's just healthy diet and control, compliance, and complication control are 3 C's.
Thank you, doctors. Thank you. As we have already crossed our time limit, so I'll take these questions quickly. Dr. Kumar, Mr. Bin is asking, I'm following from Iraq. Thank you, Mr. Bin. Patient with type 2 diabetes, taken tablet for diabetes per day. In addition to, I believe the question is already on the screen.
Yeah, but it's getting changed also.
Yeah, okay. I'll just keep it. The question is, one, is any complication of medicine can be easily used and followed? Second, is patient can be recovered totally from diabetes and back to normal life? I do support the idea of not changing the doctors unless logic reasons behind. Thank you for following this webinar and listening to our doctors. It is a very valuable information. So quick answers, doctor, so that I can just quickly finish other questions in queue.
We try to get the combination of medications which are easy to use, which are prefixed combinations and with less complication and no risk of hypoglycemia, low sugar. And yes, patients in early stage of diabetes, if they get the proper guidance, if they lose weight, if they change their lifestyle, there's a chance that they can go back to the normal life. And there is a possibility that medicine can be stopped, but then they have to commit to themselves with the lifestyle modification, and under proper supervision, it should be done. Yes, it is possible. We cannot say it's a cure. It's in remission. That means you will be medicine free and your sugars will be normal. Yes, it is possible, but in early stages of the disease, not after 10 years.
Thank you, doctor. Mr. Derek is asking, HbA1c is normal and fasting blood sugar is ranging from 103 to 115. What is your thought about it?
Yeah, it's a very common observation because HbA1c is an imperfectly perfect test. There's a lot of things which can affect. So in this situation, next time when you do the test, do the glucose tolerance test, because that will be the deciding factor. You still have the risk, you are a pre-diabetic, because whatever is abnormal is considered as diagnostic, whether A1C or sugar. So if sugar is high, that means you are pre-diabetic as per sugar ranges. So you are at risk and you have to take due precautions and measures to prevent the development of that. Next time, get the OGTT done. In some patients, HbA1c may not be a true measure.
Oral glucose tolerance test will be the best choice now to proceed with. Ms. Preeti is asking to Dr. Kumar if the diabetes levels are controlled. Her husband takes diabetes medicine from age 30. Now he's 40. Going forward, what all things to be taken care? Have a hereditary of bad control for parents? Yeah, hereditary of bad control is a lesson which you should learn from. And if your parents have developed any of the complications, bad complication, that's the second lesson. So I always tell the patient that you should learn from your parents if they have done some mistake and if they have undergone some bad complication. That's the first lesson. The second thing, if he's controlled, that means he's doing good, and I would like him to be controlled throughout, because he's only 40 now. He started at the age of 30, and as Dr. Wissam said and Dr. Lamba said, that there is the longer the duration of diabetes, more the risk of complications. So these are the most difficult patients, because for next 30 to 35 years, we have to keep them under control. And that's a challenge for the patient as well as for the physician. So if he's controlled, maintain him in the same level, and I'm sure that if he maintains like that, he will not develop any of the complications. Mr. Nachiket is asking, what are the ill effects of metformin on the body consumed for long duration? Just for everybody to know, metformin is considered as one of the preferred first choice for newly diagnosed diabetes. Okay, so long-term metformin mainly is a vitamin B12 deficiency. In 30% of the patients who are on higher dose of metformin, they can develop B12 deficiency because it can interfere with the absorption of vitamin B12. Now, some of the patients may develop the GI side effects like gastritis or diarrhea if we are using the higher dose, but if the smaller dose, if they don't develop any problem, it's mostly tolerable, and we can use the extended release preparation. Thank you, doctor. As we are almost crossed already the time, I believe we need to have back-to-back long sessions about diabetes, and diabetes is itself a journey, cannot be completed in 1 hour. So I'll take a few last lines about at least a quick message for everyone to know from your perspective. For me? Yes, doctor.
Two lines. Diabetes is a disease of discipline. More you are disciplined, lesser it will harm you. The second thing, the diabetic person who knows the most gets the least complication, who applies the knowledge. Having knowledge is not only subject, you to apply it timely.
Thank you, Doctor. Dr. Wissam, both in English and Arabic for our audience to know, a short message for all of them to know.
English, I advise all the patients with diabetes, especially if they appear to be healthy, they don't have any symptoms, to visit the heart doctor at least once to make sure that the heart is okay and not affected by the diabetes, especially if it's long-standing. In Arabic, نصيحة لكل مرضى السكر، خاصة المرضى اللي بيعانوا من السكر من فترة مزمنة، أنصحك إن أنت تزور طبيب القلب على الأقل مرة للاطمئنان على القلب والتأكد إن هو ما تأثرش من السكر المزمن. شكرا.
Thank you. Dr. Lamwar?
I think I already mentioned, Dr. Asia, 3 C's: control, compliance, and complication management. From my point of view, compliance is the key. Form a calendar when you need to see your every physician, and just follow regular appointments so that we help you keep tab on your disease, for a long period of time. That's it.
I would like to bring, I just want to say thanks to my colleagues for bringing this whole lot of information today for this webinar. And definitely, this was just a starting. We're going to have more sessions, whether it is Diabetes Day or not. We're going to increase the awareness. I would like to share very important information to all the audience that recently we have, in association with Apollo Health and Cognitivity, we have grouped the AI integrated tools, which are highly comprehensive with a deep learning algorithm and holistic artificial intelligence based risk score and risk assessment, specifically for early CVD risk, pre-diabetes and brain health. These test analysis is designed to help you better understand your future risk of diabetes, heart disease, or dementia, to predict risk, prevent premature health events, and overcome chronic lifestyle diseases. So this is very important for all of us to know, so that even if you don't want to go for the blood check, let us still, we believe in technologies these days, and artificial intelligence enhances preventive care. So let us not only talk about disease management itself, but let us also believe in prevention of diseases. So while preventive care has a long been critical element of healthcare industry, these services has become even more significant in the context of rise of heart diseases and specifically newly diagnosed diabetes cases and stress in general. Enhancing these methods with artificial intelligence can lead to a reduction in number and translate to better patient outcomes for your well-being. So as I say, Prime Health, in collaboration with Apollo, Pro Health, and Cognica, has introduced digital health solution that integrates personalized health screening, predictive risk scores, and cutting-edge diagnostic with clinical evaluation from a dedicated team of medical experts to lead you a healthy tomorrow. Definitely, AI, we don't believe the machines can only take care. This has to go in accordance with your primary physician. So if you're already meeting your primary physician, make sure that you also know the risk factor for you in getting into diseases in the future. So thank you very much. This was Dr. Asia with you. We'll meet you again in the next session soon this month. Thank you, and have a nice day ahead.
Thank you.
Thank you,
Dr. Asia. Thank you, Dr.
Thank you.
Dr.